welcome to Melbourne. I lived here for 30 years, and when I got up this morning I realised why I moved to the Sunshine Coast. This is our second activity-based funding conference, and it's great to see so many people here. Some of you here to learn. Many of you I know have been collaborators either at the Commonwealth or state level in helping introduce really what is a major revolution in funding in Australia, and I'll talk more about that in a minute. Last night I talked to my daughter, Nicola. Nicola is in her final year of nursing. She's tried occupational therapy, psychology, and decided nursing's the go. So she said, "Dad, what are you doing in Melbourne this time?" And thanks, Nick, I'm happy to be here. So I'm talking at a conference tomorrow. And she said, "Oh, conference, can I come? What is it?" And I said, "It's about activity-based funding." And I said, "Do you know what activity-based funding is?" And she said, yeah. It's where you get paid to be active." And I said, "No, not really. It's kind of like that." And she said, "Well, what is it?" I said, "Have you heard of case mix?" And she said, "Oh, yeah. We have to fill out all these forms and documents because we're told that if we don't do it, the hospital will miss out on funding." So I said, "You're getting closer to the mark there." But I'm not sure her respect for her father increased at all from that little conversation. But anyway, what we are doing is incredibly important for the Australian community. And one observation that I would make is that as ABF systems become more mature, we tinker more, we fine-tune more, and sometimes we forget why we're doing this. So I think it is important to set the scene for this conference by talking about, why is activity-based funding any better than the system we had before? What always strikes me is the issue of fairness, and that's from many years of allocating funding to hospitals and being very frustrated that the people with the most profound arguments or the best political connections are the ones that get the most money. In fact, I can remember when case mix was introduced in Victoria. I was running a couple of hospitals, so I was on the receiving end. One of the big hospital operators wrote an article called "I don't want case mix for Christmas." And that particular hospital system, some of you might remember this article, that particular hospital system actually showed up as the most inefficient hospital. And for me, thinking, well, people are out there doing work, they should be funded fairly for what they do. Related to that is the issue of transparency, that there are no secret deals, that the basis for funding is transparent, upfront, and somehow that builds confidence in the funding system and in the hospital system that we are getting a fair deal out of this in a transparent way. Efficiency, well, I guess IHPA's job is to set the national efficient price, so somehow we should know something about efficiency, but we struggle with this word. But it is essentially about trying to push people to operate and deliver services at benchmark prices, at benchmark costs, which is a little bit different to productivity. Productivity is the part that I really like about ABF, because essentially having a lot to do with people at the front line over many years, the frustration they have is that more and more work gets loaded onto them, but they don't get paid any more for it. So I think the idea that within caps and limits that if you do more, you'll get paid more is somehow in itself a sense of fairness. And finally, once you've got an activity-based funding system, only half of the equation is that we have a currency. The really important part is, what do you want to buy? And I'll talk a little bit more about that in a minute, because I think that's the maturing of the system, not just trying to fine-tune, what is this price right for this DRG, etc., etc. It's really about funders taking a very deliberate view with good input from frontline administrators and clinicians about what does the community need, what should we be buying. So just a little progress report. Victoria and South Australia, I'm still waiting for the definitive evidence on who got there first, but we both know both got there about 20 years ago. There was a little hiatus in the last 20 years or the last 18 years when people wanted to use ABF for benchmarking and benchmarking alone, which I personally regard as very soft. The benchmarking becomes profound when it's actually the basis of your funding system. I wouldn't underestimate the degree of difficulty that states and territories have had in implementing ABF. It is really an extraordinary achievement. It can go wrong so easily. Victoria's introduction of ABF, while it was trailblazing and praised at the time, at the hospital level, the price was set at a level that was much lower than the actual cost of delivering services. It forced a level of productivity that probably the system couldn't absorb, and I think the way Victoria coped with it is to draw out the reserves that hospitals had. I remember talking recently to the president of the Canadian Medical Association, and they wanted ABF, but they couldn't work out how you could implement it. But you've got all these different hospitals delivering at different rates. If we implement it, hospitals will close. They'll be, have to close 10 wards. We can't figure out a way in which we can do it. And when I explained that in Australia, the normal way is to have transition funding of some sort and allow hospitals the time to adapt to the new system, the penny dropped. And that's exactly what's happened across Australia. So I take my hat off to the states and territories beyond Victoria and South Australia who have taken that very great challenge of how to implement a system, allowing people to adapt to it, but making it clear that there is a new system available. We now have a single ABF currency for Australia. We're not the Tower of Babel, and I think that this is a major contribution that IHPA and IHPA's staff have made in collaboration with many of you here. It's impossible to be transparent, to benchmark, to work out who is more or less efficient unless we're measuring using the same currency. This has not been an easy task, and many states and territories have had to adjust the way they count, what they include in a DRG, for example, in order to be able to get a single currency. So I again thank and acknowledge people for the willingness, I think, to compromise in order to come up with one system. For those of you that travel to Europe these days, Europe's very easy. It wasn't always that way when we had liras and francs and whatever, and that's essentially what's been created in Australia, a fair basis for comparing hospitals in different states. We've extended beyond ARDRGs. Australia, many of you know, 20 years ago led the world in the development of ARDRGs. In fact, we still sell our system to many countries in the world. They actually read a little bit like the World Cup soccer in some of these obscure nations, but people have acknowledged that we led the way. What's exciting about what's happening now is that we're taking things to the next level. We've started with classification systems for outpatients, A&E, subacute. We've developed a system for costing the block funding of small rural hospitals. These are world-leading developments, and we have much more work to do over the next little while. I'd like to say that we have a clearer understanding of what is a hospital service. IHPA's most difficult task was to define what a hospital service is, recognising that a hospital service is not a service that happens in a hospital. And that has been a difficult task. I think that the authority has set clear criteria and people have responded to that by giving good, solid evidence about what should be included as a hospital service for the purpose of Commonwealth funding. Finally, I'd like to say our data is fantastic, but I think the best I can say is that we are moving closer to having very solid costing data. I really want to emphasise the importance of this because the foundation of everything in ABF is the costing data that is produced by states and territories and underneath that by hospitals. It is an effort to get that data, I understand that, but it is the foundation, and certainly the introduction of ABF as a funding tool has forced people to look at their data in a different way and try and clean out what's wrong with it, but we have much more work to do. So that's the process of putting ABF on the ground, but what about the potential outcomes? What was ABF supposed to achieve? I think where states and territories have moved is beyond just having a currency. There is much closer attention to purchasing frameworks, commissioning, call it what you like. It's now becoming the main game, and I'm very impressed when I read the purchasing frameworks, policy frameworks, that people are putting a lot of effort at the central level about what behaviours do they want to influence, what services do they want to increase and improve. There are some very early signs of narrowing in the variability between hospitals. At IHPA, we think that part of the success, the efficiency success, the benchmarking success of ABF is that bell curve distribution of hospitals, particularly at the end of very expensive, starts to narrow. I can't say we've had enough costing studies yet with good, reliable data to confidently say that's happened, but there is some evidence that the pressure of ABF is having that desired effect of getting the least efficient hospitals to operate more efficiently. Case mix and ABF is not pure in its incentives. It has the potential to seriously distort incentives across the system. For example, activity is just activity, so let's just do more, not necessarily do more of what the community needs. We think so far in our analysis of what's been occurring since the introduction of ABF is that we don't see those big distortions. We see certainly changes in data quality, but I think that's expected in the first couple of years. The fear about discharging people too early, increase in hospital readmissions, we don't see that. The fear that overall the quality of healthcare will decline, we still, again, haven't seen evidence of that, but we're always open to that. Is there a change in public-private mix? Our brief was to make sure we didn't play with those incentives, that it was in fact neutral. No incentive to give preference to private patients or public patients for that matter. The data is saying to us that in fact that has changed. There has been an increase in the proportion and the growth in private patients in public hospitals. We are yet to be convinced that that's because of the funding incentive that we've created, more to do with the states trying to maximise revenue from private health insurance through some very clever and assertive means. I think the other outcome that impresses me is the engagement that's occurred between jurisdictions, between academics, consultants. Probably many of you in this room have actually done work that's fed into the national efficient price that we have. The big discussion at the moment is the federation. Can the federation work? And the government is producing a white paper on the federation. My observation is that the work that's gone on over the last few years in ABF demonstrates how the federation should work. Some leadership nationally, but a grounding of that from states, territories and various stakeholders, but particularly from states and territories. I like to think that the way that we conduct our business by giving people access to all of the data, all of our thinking in a very transparent way, becomes our quality control mechanism. You find things wrong with it, you find things that you think should be improved, and that only ends up with a much better outcome. In fact, I think in many ways what we've tried to do at IHPA is embody those principles about ABF, being transparent, being evidence-based, being open to criticism, to improvement. To me, that draws out from everywhere the best skills and talents that are available in the country, and I think that's been crucial to the success of ABF. That's reflected in the extraordinary quality of the submissions that we now receive, particularly from jurisdictions. They've always been good, but this last year, I guess, when ABF cuts in fully, they have been quite extraordinary. They're not just giving us technical advice, they're tackling policy issues, should we go this way or that way? And again, it's very influential on the pricing authorities' deliberations. I guess at the end of the day, the way the governments might judge the success of ABF is not just whether the bell curve is shrinking, but whether the overall costs of the system are growing at a more moderate rate. This graph's just showing the average growth in cost per NWOW FY8 to FY12 before we had NEP, about 4.4% per annum across the country. Over the last three national efficient prices, it's been 2.1%. I'd be the first one to say that this is not just a matter of IHPA or ABF. There are many other factors at work here, including a desire of states to improve productivity, improve efficiency, constraints in funding, and I guess overall a very constrained wages environment across the country. So there have been in the last few years no great wage breakouts for doctors, nurses, anybody. There's been quite a discipline across the country. Maybe activity-based funding focuses one's mind on that, that you don't want your state to suddenly become the most expensive one in the country by having some out-of-control wages increase. But these are good signs, I think. So I guess the elephant in the room is the budget, and what does it mean? Put simply, the Commonwealth has said that from 1 July 2017 it will not use ABF to fund states or fund hospitals. Instead it will go back, in a sense, to CPI plus population growth. It proposes to amalgamate, I think, 6 agencies to create a Health Performance and Productivity Commission, although that is contingent on what the states say about whether they want that to happen. That will include IHPA and NIPA. It's important to reflect on the policy intent of what the Commonwealth is doing. I don't read it as the Commonwealth saying, and the Commonwealth Minister saying, we think ABF's a bad idea and we should abandon it. In fact, in my discussions with the Minister, quite the opposite. It's more of a very high-level position about what should the Commonwealth do in telling the states how to run their hospitals. So they believe, I think, that ABF is a more intrusive form of funding than fits their model of the Federation. So I think that's also reflected in the fact that that this change in funding doesn't come into 1 July 2017, giving IHPA or its successor 2 more NEPs and NECs to create. And I think part of what's behind that is to ensure that the system is embedded across the country and still consistent. I would watch two white papers at the federal level, one on the reform of the Federation and the other on the reform of taxation, which I think will influence things. So meanwhile, I think the challenge for us all, and particularly, it's a very challenging time for the staff at IHPA, who I would say have done an absolutely extraordinary job. They have to keep doing what needs to be done. Which ones of those other functions that IHPA does, like classification, etc., continues in the new body, if the new body is created, will, I think, depend ultimately on whether the states and territories decide they want some national work on classification, on benchmarking, etc. They want a consistent currency to continue. In terms of IHPA's work program, Tony will talk more about that, particularly in terms of the classification development, costing development that's underway, that I think is crucial and really has to be continued in the future. We're about to put our consultation paper out. Our normal routine is this time of year. We put a consultation paper out saying these are some of the issues we're thinking about, changing or not changing in response to submissions we've received in the past. We put that out. We listen to responses actively and seriously invite responses to it, and that then leads into a draft pricing framework and ultimately into the determination in February next year. So it is quite a lengthy process, but it's important that people get things on the table. Just to mention some of the things that are in that consultation paper that the authority is grappling with. Should we move towards a more bundled pricing model, particularly out of hospital? We have been grappling with this. There aren't a lot of good examples around the world of bundling that pull together what happens to a person outside of a hospital. And if you remember why were DRGs invented in the first place, it was in fact to bundle what happened in hospital, so you weren't paying for bandages and individual drugs, etc., etc. The same, arguably, in the world of chronic disease and aged care should probably happen outside of hospital. So we are actively exploring bundling possibilities. The national efficient price, we use the mean. We're canvassing, perhaps we should think about what that means now that the system is relatively well embedded. For example, should we take out of the calculation of the mean, the 10% of most inefficient hospitals, because they push the mean up. So these are the sort of things that we're thinking about, and there are a few other considerations in the consultation paper that we want to explore some more. We keep on looking at what other adjustments to the NEP should be made, what are legitimate, unavoidable cost variations. We remain open to any evidence, even when we've looked at issues in the past and haven't found the evidence. Sometimes the evidence takes time to emerge. There's an issue around telehealth and which ends of the giver and receiver of telehealth should be funded. Both ends. At the moment we fund one end. A number of states fund both ends. Issues around multidisciplinary case conferences, particularly those where the patient is not present. At the moment they're kind of not recognised, but we know they're a very important part of the service system. These are just some of the issues, more around policy issues for consideration that we're looking at. So what does the future hold? My view is that once you have ABF, it's a hard habit to kick. You get used to it and confronted with, yes, this is all difficult. My daughter will have to keep on filling out bits of paper. But I don't see people move from ABF back to some historically based funding system. And again, because of those issues of transparency, fairness, productivity, etc. I think the key focus will increasingly move to how to use ABF as a purchasing tool. States are, as I mentioned, experimenting with lots of different levers, but I think a policy framework around when should the states as system managers try and influence activity on the ground, when should they leave it alone, remains to me, the most difficult funding policy issue. If I can put finally an ad in for IHPA and the fantastic work that staff have done, I firmly believe that there needs to be continued work on the national development and classification and costing that brings together the best talent in the country, because it's only through that we'll have proper benchmarking across Australia. But that future, I think, will be decided by states and territories. So enjoy the conference. It is a time to, I think, celebrate what has been achieved. It is extraordinary by any international standard. It's also a time to challenge ourselves about what could still be done, and a time, I think, to showcase the tremendous work, the thinking, the deliberations, the way people have implemented ABF across the country. So thank you very much and enjoy the conference.